Good afternoon, ladies and gentlemen. It's a pleasure to be with you. China, thank you, Medtronic, for inviting me to this beautiful symposium, which is, of course, sponsored by Medtronic. I will review with you my experience during the last more than 10 years with Pipeline, especially with the sub-analysis that we had already with Shield. That experience has been done in our center in Buenos Aires, thanks to our fantastic team that we have here. I must be very grateful to all of them for the help, especially to my fellow from China, Hongji. He spent almost 2 years with us. That was a grateful experience. Let's do an overview of flow diversion. We will speak a little bit about the focal and segmental disease, especially the Buenos Aires experience with flow diversion. As you know, the formation, growth, and rupture of the aneurysm is a very complex problem that we have studied with Daniel Rufinas, with Professor Rufinas from Zurich, and extensively. We share with our colleagues from neurosurgery the external condition. We are very good on the internal condition, but the wall is a problem for both of us. And the optical coherence tomography will come and help us. That was developed by Matthew Gonis, and I think that will change everything because we will see now the wall. The coil experience has been fantastic, but we had a recanalization problem, and also we have some thrombo-embolic complication, as well shown by Yuichi, Murayama, and UCLA group. We started very early on with stents back in 1996. We treat that male with dissected aneurysm with stents. At that point, we realized that we had some potential treatable cases or untreatable cases back in the 90s. That I think with stent we made them really treatable, potentially treatable, untreatable in 2022. I think we are believes that the flow diversion is designed by segmental defect, which is a damage of the artery that involves more than a quarter of the vessel circumference or the same distance in length. So this is we really prefer for segmental disease, flow diverter. Peter Kim Nelson, Quang Tran, and Aaron Bay did a fantastic job with Pipeline. I tested at that time, and we understood from them the concept of flow modulation more than the concept of flow diversion, I think. As you can modulate the flow very nicely in the water fountain, I think we are able to modulate the flow on that particular segment here, ophthalmic segment with 4 aneurysms from the neck of the proximal, the ophthalmic come off. So what happened once we really insert a flow diverter? Well, you see 9 months after, there is a complete occlusion of the 3 aneurysms, the distal one, but the first one remained open because there is a channel taking off from the ophthalmic artery. And what happened with the follow-up? Well, you will still modulate the flow over the time at 3 years, 6 years, so showing the shrinkage of the aneurysms and the patency of the ophthalmic artery. So we really, with flow diverter, we do a circulatory exclusion by positive remodeling. During those years, we took advantage for any single developments in our field. We see much better. We have new tools. We got the help from bioinformatics, and of course, we use a lot of the everything from translational research. So in Buenos Aires, in 2006, we do vessel repair by flow modulation. We have been doing that for many years already. But we must take into account everything about the patient, not the device, nor the aneurysm. We have to take into account the things related to the patient, his history, risk factors, anatomy, and so on. For us, this is very, very important. We favor the treatment with flow diverter and unruptured aneurysm. This is our first option. In ruptured aneurysm is clearly it's not indicated for us. It's our last frontier. It's a last resort. In 2005, we did animal lab with flow diverter in Buenos Aires. We did our first and main 2006. Since that, we have implanted more than almost 3,000 flow diverters in Buenos Aires. We were part of the PETA cohort, which was the first one. And of course, we published our first series in 2009. So we were very active on flow diverter. Our first complication, bleeding, was published in 2011. What were initially our indication? Well, the wide neck aneurysm, the fusiform, but mainly the severe segmental defect. That was our goal at that time. With the time being, we learned a lot of the indication, how far we can go, how long they can last. But mainly, we learned about the hemorrhagic complication and the thrombo-embolic complication. So that was a learning process that we showed that we were very safe. The most important thing, we were efficacy. And we have a long, today we have long-term follow-up. We have 10 years follow-up. So I think it's a very adequate. At the beginning, we were targeting proximal with multiple devices. After that, single device, more distally, of course. And the EVERT trial became PEDESTRIAN register over the time. That was our first publication in neurosurgery many years ago. And now we publish the PEDESTRIAN study also in the same journal. Where will be the place for that registry? I think it's an important one because we have 87%, almost 88% of the angiographic follow-up at more than 5 years. We have 96% of our series complete occlusion. So what is the PEDESTRIAN? It's a 1,000 aneurysm registry done from March 2006 to July 2019 using PED Flex and Shield device in our center in Buenos Aires. Initially, of course, we treat arterial circulation, but with the time being, we expanded to more complex aneurysms and also some of the posterior circulation. Over the time, we got more and more experience, but this was our first case, AVM, with an aneurysm that was treated elsewhere. So we had to retreat it, complete exclusion of the AVMs, and the aneurysm was seen 6 years after. You see, those are the artifacts from the coil, but you see how nice is the posterior remodeling in the artery. You can see here the complete exclusion and the posterior remodeling of the artery. So we use a little bit more than one PED per aneurysm. A lot of comorbidity in our series, more than 50% with comorbidities. Multiple aneurysms, 1/3, less than 1/3 of our series are multiple aneurysms, but more than 1/3, 35% exactly, were large and giant aneurysms with the complexity that you will understand. Of course, we had intraoperative complication of 4.8%. Our rate of complete occlusion at 1 year was 75%. At between 2 and 4 years was 92%. So was really increasing over the time. What will happen with more than 5 years? Well, 96% were completely occlusion. Most important, in the first 30 days, the ranking was stable in more than 90% of the patients. As well was stable and exactly 97% in the last follow-up. The retreatment rate was 4%, all-cause mortality 4.6%, but neurological mortality 3%. We had all kind of complications. We have stroke, hemorrhage. I will come later on more explicit for that. Again, angiographic follow-up, it is 87%. And I think the rate of exclusion was very, very comparable to PAF, to Intrepid, to Aspire. Let's compare 5 years to PAF. PAF has 95%. We have very close, 96%. So I think it's very comparable in everything. But what about the compare complication? Well, our rate of major morbidity and neurological mortality was 5.8%. PAF was 5.6%. So all-cause mortality 3.7 PAF, 4.6 our mortality. So overall, I think you can compare. Let's have a look on the Shield experience. In that particular cohort, we have 302 aneurysms treated with Shield in that series. We had more multiple aneurysms in the Shield cohort, 45%. That means we are using probably less than 0.88 for the overall series. Complete occlusion rate at 1 year still 75, 92, and the intermediate phase of follow-up. And let's compare Shield and PEDESTRIAN. Major morbidity was less, neurological mortality was less, combined M and M was less, and all-cause mortality was 0.8, comparing with the PEDESTRIAN. So I think let's compare the complete occlusion rates, very similar, 78, 76, 93, 95%. So I think you can compare fairly, and the Shield subseries compare nicely with the PEDESTRIAN. Overall conclusion of that series, at multivariate analysis taking into account age and non-circular morphology were identified as independent predictors of worsening of their MRI, of the ranking scale. We found a trend towards lower rates of thrombo-embolic complications since we implement Prasugrel in our PEDESTRIAN cohort. And Shield clearly was a trend toward less thrombo-embolic complication with PED. And that was comparably face-to-face PEDESTRIAN and Shield. So overall, I think the PEDESTRIAN was the larger study and showed clearly that we were safe and effective. Regarding Shield, thromboembolic complications were really lower in that particular sub-analysis. So let's have a long-term follow-up look, and also distal, very distal analysis. This is a particular case that was already published, anterior communicating complex with severe mass effect, as you can see there. That I came from A1 and the right to A2 and the left. You see over the 1 year and 7 year our follow-up. Nicely, you also will see probably what happened with the device with an X-ray. You see how it changed the morphology when you have less mass effect at that time. So let's have a look on more complex aneurysm. This is really a huge aneurysm in a lady 71, compressing completely the left side, and also she's losing vision on the right side. So we know that will be very difficult. And those aneurysms, the exit sometimes is a problem to find an exit at the reconstruction completely the artery, because there is no artery there. So you can take advantage of the stent driver technology, balloon technology, and you can straighten everything. I came to M2 with one system, A2 with a second system, and I was able to really overlap 3 devices with the device technique. And that is 4 months follow-up, still some remaining, but you see what happened in 1 year, complete occlusion of 1 year. We did some cases that the patient bled, was clipped twice, and it was still some remaining there. So we did 46, this is 46 month follow-up after we deployed one single device showing complete occlusion of the aneurysm. With the time being, EV3 bought Chestnut, that was EV3 was acquired by Covidien and actually Medtronic. So what happened to us, to our physicians, really was very good, because they still invest on research, and they came with the Shield technology, which I believe is a superior technology, at least in our hands, that prevents some thrombus formation due to the phosphoryl surface modified flow diverter, that as was shown by Matthew Gonis from UMass. And this is one of the cases. This is a blister line that bled, you see, and in 48 hours you will see how it's expanding because there is some absorption of the hematoma here. So we were able to implant some coils there, also flow diverter. And this is, I believe, 3 months follow-up MRI showing no thrombo-embolic complication on MRI, and most important, complete occlusion at 6 months of the aneurysm. And another case that we favor Shield was this lady with Ehlers-Danlos syndromes that we reconstruct everything from intracranial distally to extracranial with 5 devices, device and device. And this is, I believe I have 1 year follow-up showing nice reconstruction extra and intracranial. But with time being, we know we have technical complication, and also we have complication due to the procedural, peri-procedural, and post-procedural problems. And I would like to share some of you. Of course, we learn from those complications. Regarding the technical complication, you can have a distal wide rupture, you can have bridge rupture. Regarding clinical complication, thromboembolic complication, and hemorrhage. Failure. We have failure because we have malapposition of the device due to the endo-leak. We have inadequate aneurysm coverage, and because also sometimes we have a branch that coming off from the fundus. The main problem for us was the previously placed laser catheter, and you go over with a second device, and you will have endo-leaks on those cases. So remember, I will show you a case that we did very badly. The main thing is wine glass. You have to push and pull, compress nicely against the artery, and don't leave a space for stretching, which is very important. I will show you a case for stretching. The wine glass is very good. I strongly recommend to you to go to the banana web and follow the Shapiro advices on that. So this is the case. It's a huge, with a severe mass effect, a huge supracranial aneurysm. M1 was very small. I deployed 4 devices, but the bridge was ruptured. So I had to capture 2 distal devices I remember with the alligator at that time. And I had to start over again from proximal to distal. We succeeded to have a complete occlusion. And this over 1 year, you see the shrinkage of the aneurysm. And also you will see angiographically how nice remodeling, positive remodeling we got in that particular case. Sometimes we have a more severe problems. We report our first 3 bleedings back in 2011. At the beginning, we thought that was related to the hemodynamic factors. With the time being, we understood that there is some aneurysmal thrombus problems because we release inflammatory markers at the time. So this is a problem. The solution of that will include new devices. But of course, in the meantime, we're filling aneurysm with coils. We implant more than 1 flow diverter. But we always do very strict antiplatelet and control of blood pressure. I think that is essential for that. You can have those complications in the hyperacute case, I show you one case, or in the chronic phase. So remember, on top of that, you have a severe anti-aggregation problems. So this is the case with the intraoperative rupture, as you can see there, and we lost the patient due to that complication. Remember, you have to have a strategy. You have to have a pre-treatment planning. It is very important. We leave clopidogrel many years ago, 6 years ago. We are in prasugrel. For us, it's very important that, and we do and verify now in all of our cases. Why is important the control of the pressure? Well, because the hypertension is the most powerful risk factor, not only for growing, but also for rupture. So I think we have to be very aggressive pharmacology induced, as our Japanese colleagues teach us. So we have a severe antihypertensive drug therapy led by losartan, valsartan, controlled by our cardiologists. Those patients remain almost 1 week in our clinic. And in Giant, we do a very severe also steroids protocol. We're still looking for better flow diverters, better surface modification, better new materials. We're working on some liquid metals. Of course, and the therapy and the endovascular therapy of brain aneurysm has been two big breakthrough. One was the coils back in the 90s, and I believe flow diverters with the pipeline. As a conclusion, I think as more experience we have as pedestrian study, we really increase complex cases treatment. Pipeline device has been a breakthrough in the treatment of the brain aneurysm, and pedestrian study to me is the largest PED study to date. It's safe, has been shown that it is really safe and effective. I think there is some duty to do. We have to understand better the biology, the healing, and the mechanism of thrombosis, and we have to work on that. And remember, sometimes change is mandatory to get better result. Saying that, I must say hello again to all of my friends from China. Thank you for the opportunity, Medtronic, and thank you for your attention during this time. Thank you very much.